Should I start?
Yes, sir.
Yes, so we are live onto YouTube and you can start, Parikshit sir.
Good evening, everyone, and pleasure to see so many people on this evening who've gathered to learn about Batch IVF. Now, I've done a lot of strange things in my life, and today Dr. Shilpa has asked me to do a really very strange thing, and that is to introduce Jay. Now, it would be quite redundant to try introducing him because this guy never gives his CV. You all know that, right? So he just says consultant, obstetrician, gynecologist, fertility specialist, endoscopic surgeon, etc. You all know him, so there's really nothing much for me to add about it. You're here on this evening at 10 o'clock to listen to him, so I won't be a barrier in terms of standing between Jai and what he wants to share today about Batch IVF. The only thing I'll say is a couple of my views about Batch IVF, and we've discussed this. In fact, we were chatting this afternoon also, that as the number of centers, the number of IVF clinics increase, batch making and managing a batch is going to be the way forward as far as efficient functioning of units is concerned. And we have to also understand that as the number of centers increase, the number of cycles that an average center, now I'm not going to say what is average, but I'm sure all of you understand what is average. So that number of cycles per center is going to be capped. It's going to be limited. So it makes a lot of sense to consider this as a form of practice. And having said that, I'll hand it over to Jay to take it forward.
Yeah, thank you, Parikshit sir, for this. So I will immediately start with the screen sharing, and Shilpa madam, just stay unmuted. Yeah. Okay, so can you see my screen?
Yeah.
Okay, fine. So what we are going to be discussing today is basically going to be batch IVF. All right. And as Dr. Parikshit sir mentioned, all right, see, it is bound to happen. When I started practice back in 2015 as an IVF laboratory, I was probably the 25th or the 26th laboratory in Mumbai. Okay, right now I think we have around 200 laboratories in Mumbai itself. All right, so it makes a lot of difference. The total number of patients are the same. Total number of doctors offering IVF has gone up. So obviously number of cases per center is going to go down, as Parikshit sir mentioned. And in order to make it more economical and more streamlined, okay, so economical and efficient, I think batch IVF is going to take a huge leap in the next 7 to 8 quarters as far as India is concerned. Okay, the important thing about batch IVF is I'll go with a beautiful flow chart. Okay, see, what is batch IVF? In batch IVF, you could be any center, but you are dependent on a fertility consultant. Okay, you are dependent on a fertility consultant or an embryologist or their entire team. Okay, so let's assume this entire team agrees to come to your clinic on today is 10th of October. So let's assume they decide to come to you on 10th of October. Okay, for doing the egg pickups. That's when your OPU is scheduled. Now that becomes your day 0. Okay, this is very important for people to understand. Okay, so what is going to be happening if this is your day of pickup 2 days before? You would have given your trigger. This is going to be the day when you would have given your trigger. Very simple, no? So now I'll come to the trigger in very quick thing. If you are wanting to do fresh cycles, then obviously the trigger of choice is going to be, as we have discussed in our previous sessions, to go ahead with 10,000 HCG. If you are planning to do freeze all, okay, then you have an option to give a simple GnRH agonist trigger, or you have an option of giving the dual trigger. This also we have discussed many times, so one can go through those previous classes. Okay. Obviously, before the patient reaches the day of the trigger, there is going to be around 9 to 11 days of stimulation. So now you are calculating -3, -4, -5, -6, -7, -8, -9, -10. Okay, so this is trigger here. So it is going to be 1, 2, 3, 4, 5, 6, 7, 8. That is your 9th day. -13. So it is going to be tentatively, okay, if let's assume on -13th day, if somebody has started stimulation, then for that particular lady, okay, let's assume this is the day 2 of her menses, somewhere here. Okay, so then this is your day 3, this is a day 4, just a reverse calculation for everyone to make it easy, right? Because this is exactly what you are going to follow, right? And on the 13th day you have trigger. Let's just put it that way. Let me also just give an overview. Now some patient has got day 2 on day -13, some patient has got day 2 on day -12. Okay, everything is adjustable. Okay, so you have that little window. Now what matters is, let's assume you have a total of 10 patients. Okay, let me just put it that way. Let's assume you have total of 10 patients who are to be stimulated, okay, in this particular batch. Okay, so all of them ideally should be reporting to you either on day -13 or day -12. Okay, this is from the day of your day 0. That is the scheduled day of the egg pickup. So then you are going to try and recruit these patients. So let's assume 1 month before you have recruited all these patients. Patients have agreed to pay the finances. Patients have agreed to do many things. No, financial counseling is done. Documents are signed. You have decided if it is self cycle, if it is donation cycle, multiple things. Nahi? -20. I will go one step ahead. Okay, and I will go actually a little far ahead in this. So -20, -21, -22. So we are going to draw an entire month for all of you now. Okay, and then we will be very easily able to discuss everything here. So now you have around 30 days to go. Let's assume a combination of your fertility consultant and these guys are coming here on 10th of October. Okay, this is 10th of October today. So this -30 is, let's assume, 10th of September, 30 days before you know that your next batch is scheduled on this day. Okay, so the guys who have been recruited here, okay, the guys who have been recruited here or before, okay, how many days they have? They have approximately 15 to 16 days. All right, now it is completely dependent on you. So I will draw something very simple and explain it to you. Okay, these days from day 14 to day -20. Okay, I will just mark these days. Okay, these have to be your washout days. Washout days means you should not be ideally giving any drug in this particular time. I will just come on to it in a little while and explain it to you in great detail so that all of them who are reporting to you on day -13 and day -12, all of them are reporting to you with these extremely small antral follicles. Okay, irrespective of the day they come to you, the antral follicles are uniformly between 2 to 6 millimeters. This allows you to standardize the stimulation on a day-based manner, irrespective of their circumstances in most of the situations. All right. Also remember, on the day of trigger, you have a wide range, thanks to God, of day 18 to 21 millimeter. Okay, 18 to 21 millimeter size of follicle. That is when you are going to give a trigger. So you have a window that, okay, day 18 to day 21, I know one day extra is not going to make a very big difference as far as my outcome is concerned. All right. Now people have this royal confusion. What do we do as far as pre-treatment OC pills is concerned? So when myself and Dr. Parikshit were discussing today, okay, after that, I actually went through that paper, where somebody had mentioned that if you give pre-treatment oral contraceptive pills, then it is going to reduce your pregnancy rates. Okay. So there is a one big mistake which they had at least quoted in that paper. They stopped the oral contraceptive pill on day 16 and they started the stimulation on day minus 13. So their washout period was just 2 to 3 days. Now, if your washout period is so less, then oral contraceptive pills is a big no. Because in that situation, your oral contraceptive pills is not going to benefit the patient at all. Okay, it is definitely going to reduce the pregnancy rates. That too, it is going to reduce the pregnancy rates if at all you are doing a fresh transfer. It is going to reduce the pregnancy rates for this category of patient for fresh transfers. Okay, if you are doing freeze-all, then it doesn't really matter because implantation in that particular cycle is not going to happen. There is a little thing that if your washout is very low, you may have 1 or 2 less number of oocytes and you may have less top quality embryos. Okay, and as a result of which, if your pre-treatment is with oral contraceptive pills, it is ideal to have a washout interval of at least 6 to 7 days. Okay, but now let's assume there is a challenge here that it is now already day minus 12 and patient has not got periods. So it is already a washout period of extra 2 days. So that means total 8 days of washout period, and you can actually start the stimulation for the patient irrespective of menses with pre-treatment OC pills on this 8th day of washout. Okay, so that you can start the treatment on day T minus 12. Okay, that is important for people to take home as far as pre-treatment oral contraceptive pills is concerned. It is very, very simple. Let's assume the patient has reported to you only on 30th. Aaj hi aaya hai patient has told, no, I want to do the IVF with you only. You are an excellent fertility team visiting from outside. So tell me what to do. So these particular patients, okay, these particular type of patients can be given any form of progesterone lining, okay, as something which is pre-treatment. So we can give for 1, 2, 3, 4, 5, 6, 7, 8. Up to 8 to 10 days, you can give either Dufaston, which is excellent for cycle regulation, and you can either give Meprate. We prefer not to give Regestrone so much because Regestrone has a very long life and we don't really know how much Regestrone will effect. But yes, Dufaston and Meprate are excellent. So pre-treatment with progesterone is also equally very good. Okay. I am not a very big believer of calling the patient on this day T minus 21 and then starting the patient on estradiol valerate here. Okay. The reason why I am not a very big believer of estradiol valerate is it abnormally increases the value of serum E2 on the day of starting, and it causes a little imbalance on 13th and 12th day because some patients with estradiol valerate might have more number of stimulation days. Okay. Remember, if you have more number of stimulation days, you can't really adjust this day 0. Okay. That is something which is very, very important for people to understand. Okay. And let's assume there is the last situation in this entire thing. Okay. Somebody just came to know that, oh my God, a wonderful team is coming here and they want to get an IVF done here only. And they've come to you mid-cycle. Okay. They've come to you mid-cycle on day 14 or day 15 or day 16. Okay. And now they are on day 9 of menses. Okay. And they've come to you and they've told, yaar, mujhe yahi cycle mein karna hai. I am ready to do freeze-all. Okay, but I want to get stimulated in this cycle. For all these patients, the treatment of choice is to do random start, and along with random start, just in case the patient has reported on day T minus 13 or T minus 14, and there is a little asynchrony, it is absolutely safe for all these patients to take pre-treatment antagonist. The reason why I'm giving such a big answer for all these questions is because all these things, random start, pre-treatment antagonist, we have taken master classes. So now you will be able to correlate how you can actually adjust your cycles for your patients. Okay. This is one thing as far as adjustment of cycles is concerned. I think there is something which is very, very important, which I want to mention. That in almost all these patients, 99.9% of the patients, okay, the protocol which is going to be used is going to be an ANTAC protocol. Okay, so these patients here are going to be on a antagonist protocol. That is the standard, and that is something really important. Now for batch IVF, some important things as somebody who used to do this a lot once upon a time. So I will mention certain important things. Now, these are very important days for you. Day T minus 20 to day T minus 14. In these days, arrange for drugs. Okay, this is important. arrange for drugs and media and consumables. Okay, you will exactly know, if you think you are going to have 10 patients, at max it is going to be a range between 8 to 13. So you know how much approximate number of drugs you are going to need, how much approximate media you will need, how much approximate consumables you will need. It is ideal to ensure that on day T-6 and T-5, you have one dry run of your laboratory if your laboratory is running just once in approximately 6 to 8 weeks. Very, very important. T-10, 9, 8, and 7, it is important that the entire area is cleaned thoroughly. Okay, because that is going to affect your success rates. Throughout these stimulation days, it is very, very important that you stay in constant touch with your fertility consultant, because remember, even if it is batch IVF, it is completely result driven. Okay, you need to provide excellent results to your patients in batch IVF without saying that it is batch IVF or without compromising on the outcomes. Okay, and that is the key to running a successful batch IVF program. If you just organize one batch and if you go haywire in that, it is not going to happen. Okay, when your IVF consultant and your embryology team is going to arrive on the day of pickup, it is very, very important on this day T-1. Okay, media is incubated at least 6 to 8 hours prior. Many times people forget to do this. Okay, before the guys come in, actually. Okay, also remember, very, very important, but a very common mistake which people make in this entire thing of doing batch IVF is that they try to compromise on the quantity of the media. Okay, it is important, especially in peripheral setups, where there is a problem as far as generators and electricity is concerned, is that your UPS is nicely backed up before you do your batch IVF. It is very important for you to ensure that you have extra CO2 cylinders. Okay, and it is very important for you to ensure that you have OPU and ET catheters at least 2 times than what you require. Okay, these are not very expensive consumables, and this should be available inside your laboratories. Okay, very important thing which people ask is when to clean the incubators. Remember, guys, I have already told, day T-10 to day T-7 is the time when you should be cleaning thoroughly. So this cleaning thoroughly involves IVF as well as incubators. Lot of incubators, especially if you are using box type incubators, they will require approximately 24 hours for an entire cleaning cycle to happen. And after 24 hours, they need to be kept closed for another 24 hours. Okay, this is a very, very basic point. If anybody operates Heracell, Thermo Fisher, they will know what I'm trying to talk about. Okay, that is the primary incubator which you have. Now, after your team has finished all these things, your team has come, egg pickup has happened on the day of your ovum pickup, and you have assessed the total number of embryos which you may get. It is important that you give clarity to the visiting guy, because from this day 0, okay, I will just draw it again. Okay, from this day 0 of OPU, it is not that the majority of the centers will have people staying till day 5. A lot of embryo transfers in batch IVF cycles especially would happen between day 2 and day 3. And for this to be successful, you need to have an excellent embryologist, biologist. Okay, I'll just use the word biologist, or an excellent clinician. Okay, remember, your result is going to be now dependent here if you have an excellent biologist and an excellent clinician. So for people who want to do good batch IVF, apart from investing in IVF laboratory, invest in these 2 people. Invest in a biologist, invest in a clinician, because they are the key people to help you grow your center. Once your center crosses a particular threshold and you are comfortable with a particular amount of growth, obviously many people pick up the skills and people like to move on. But in your initial days, we have seen a lot of people who compromise in this particular investment, and then their program never really picks up. In fact, I always joke with Dr. Parikshit that, many people who enter the IVF fraternity and the IVF industry are often in that belief that once you do an IVF program, from the first batch itself, you will start making a lot of money. That actually doesn't really happen. Okay, it takes some time for the things and the laboratory and everything to settle down. And once things settle down, usually for people who are doing their initial batches, I strongly recommend them to try to program their results as quarterly results or 5 to 6 monthly results when you are starting off. Do not try to program your results as that, okay, in the first batch I had 90%, next batch I will have 100%. Nothing like that. Keep realistic expectations in batch IVF. Okay. Another important thing which I want to tell a lot of people, as far as batch IVF is concerned, trust me, IVF is one program which every fertility consultant or every gynecologist can do. Okay, this does not really require a massive amount of learning curve. Okay, this doesn't really require a massive amount of learning curve. Okay, and you must be able to do this. Okay, so with this, I will again start to screen share because I want to cover one more important thing. Shilpa madam, I'll go with the screen sharing. Okay. We currently discussed the stimulation. Okay. Now stimulation is one part of your journey. Okay. If you are doing fresh cycles, then I already told you on day 2, day 3, it will be done. But if it is a freeze-all cycle, okay, and you have to transfer some embryos the day of the visit. So again, day 0 is the day of your embryo transfer. Okay. And I'm assuming that everybody will have a blastocyst. Okay. That is a day 5 embryo. Okay. So now you reverse calculate. -1, -2, -3, -4, -5. Okay. So just let me write down everything fast. This is also very important because people really, but this is so easy that you will feel, Gary, this was really easy. You know how to do FETs. -20. Okay. Now, what should be the day of progesterone? It should be the 6th day of progesterone. So this is your 5th, 4th, 3rd, 2nd, 1st. So if your clinician is arriving on day 0, it is on day -5. Here that you should start adding progesterone. Endometrial thickness here should be more than 7 to 7.5 millimeter. Serum progesterone, if you have the facility, less than 1.5. Serum estradiol, if you have the facility, more than 300. This is predominantly we are discussing for HRT cycles. And when you do batch embryo transfers, it is absolutely convenient to do HRT cycles. Very tough to do modified natural cycles. Impossible to do true natural cycles. Okay, so keep that in mind. When you have batch, it's going to be HRT cycles only. Minimum number of days of exposure of estradiol which you need is going to be at least 9 days. Okay, so I am presuming, let's assume estradiol was started somewhere here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So see, you have a huge window here. You have this huge window to adjust the patients, as a result of which you can start estradiol for these patients right from T-18, 17, 16, 15, 14. Okay, this is something which you need to keep in mind. The standardized dose of giving estradiol valerate, at least when I was doing the batch, is 101 for 6 days, followed by 111 for 3 days. This 111 can be added for another 3 days in order to adjust the batch. Okay, and again, very important, when you have this on day T-1, you must culture the media. On day 0 in the morning, you must ensure that thawing is done the first thing, and just in case you are doing hatching is done after that, and then you have any time between 2 to 7 hours to go ahead and transfer the blastocyst embryos. Okay, just in case you are doing a freeze-all batch, you know, so in that single day when your clinician or your fertility friend is available to help you out, you are able to sort out so many things for that, so that single day visit becomes extremely effective. Okay, I also think, I'm not very sure, but these days in India, the amount which a fertility consultant of a good level charges for doing a batch IVF per case, per cycle, I think it comes to around 20,000-25,000 rupees, which probably includes the embryologist as well. But then you can find out based on your local requirements as to what is that. All right. So with this, I finished this entire session trying to probably cover everything which I could. as far as batch IVF is concerned. And I will be now happy to answer questions, should there be any.
Yeah. So you told about the pre-treatment OC pill and pre-treatment progesterone. What about pre-treatment only estrogen? I mean, do you believe in it?
As I mentioned, madam, when we do estradiol valerate alone, that serum E2 level on the day of starting treatment is slightly on the higher side. Okay. This may require additional 1 to 2 days of stimulation. Okay. And that is a little time killer, which is why I don't prefer it in batch IVF.
Okay. And what is the ideal number in batch IVF? Like, say, 25 cases, 10 cases?
It really depends on how good your unit is, madam. How many incubators do you have? Okay, it actually depends on that. So a single good incubator, let's say a mink, would adjust approximately 8 patients. Okay, in a single incubator. If you are using a plate which is a center well plate, 99% of the people would use a center well 3037, the code of the plate. Okay, but it depends. Okay, there are people who would adjust 16 also in a single mink. Okay, all these types of things happen. But I would normally say if you have 2 to 3 incubators, it is good that you will be able to do approximately double-digit cases. Just take it that way, because you will also have embryo transfers. And when you have embryo transfers, you will also need to culture the embryos for the embryo transfer. Correct?
Okay. And so how many have you done in your practice, the maximum in batch IVF?
I think once when myself and Mohit had gone to somewhere in Warangal, we both had done 24 in that batch.
Okay.
Mohit means Dr. Mohit Sarogi. Okay.
So, like, what all do you check from the embryology perspective? As in there may be variation in the batch to batch consistency of all these like culture media and all that. So how do you ensure that things are okay? Like breakdown.
This is, that's the reason why I said that you need to incubate the sample or the media on the T-1th day. All right. So when you need to do that, you will notice on next day morning, because of the pH change, there is going to be a slight color change. Okay. Of the media, that pinkish media, that pinkish color of the media will fade a little. And because it fades a little, that is your first indicator that the pH is correct. That means the incubator is correctly calibrated. That means the CO2 is correct. That means the CO2 cylinder is purified. Okay. Because quite a lot of times people have incubators which only accept medical gas CO2. They don't have dry gas cylinders. Okay. So that is something which you have to keep in mind.
And what are the problems? Like, I mean, you're doing 10 cases, 15 cases at a go. So what
timing?
about?
See, timing is the biggest thing. So always what we used to follow is that you keep an interval of at least 25 to 30 minutes between the 2 pickups. So on the T-2nd day, your nurses will be awake the whole night, giving triggers to those patients. Because you need to ensure that somebody gets a trigger at 9 in the night. Somebody gets a trigger at, let's say, 9:30, the other at 10, then like that 12:30, 1:30. And people in the periphery will tell you that, look, if I take the trigger at 1:30, I will not be able to reach home. Understanding? So you keep me in the hospital on that day. So that is very, very important. Simultaneously, it is important that patients in a batch IVF take the trigger in the hospital. Okay. If you ask these people to take trigger at home, it has happened with us. 6 people one time took trigger. Everybody took trigger at 10 o'clock. Okay. So then it becomes very tough to adjust on that particular day. Very, very tough.
So, what is the minimum time gap? Half an hour is what you do?
No, in a batch, see, that is the time which you will need for shifting. See, on an average, madam, if let's say there are 15 eggs, okay, you will need 2 minutes to do the egg pickup, correct? But the patient will have to come in the OT. Anesthesia has to be given. Okay, if you are giving anesthesia, your anesthetist has to be comfortable. Patient has to be shifted out. Hundreds of things will happen, right? So give that half an hour buffer.
So, what are the minimum days of contraceptive pill that we need to give? And
see, anywhere between 12 to 15 is good. Okay. Again, you have this 3 to 5 day break. You can give it for 18 days also, just in case you want to adjust the batch for everyone together. See, I have written that washout of 6 days, but very commonly it is going to happen that if you give OCPs for 12 days, patient will take 7 days to get periods. And if you give OCPs for 18 days, periods will come in 4 days. Understanding? So let's assume somebody got periods in 4 days. Now what you will do? Correct. That one guy has got periods early. I told, give pre-treatment antagonist. Correct. You give pre-treatment antagonist for 3 days till that last guy gets into periods, and then you can start stimulation.
So if they don't get the periods at all, what do you do?
No problem. 7 days of washout is more than enough. Even if you don't get periods, start the stimulation. There will be so many patients on stimulation who will get periods.
So in all these cycles, like where you use OC pill, so do you recommend HMG or RecFSH?
Everybody in batch IVF is on a single drug of HP, HMG, whatever is the choice of that particular fertility consultant. I would never, that time used to never give a choice. I would always tell them that, boss, you are supposed to buy this. Okay. But normally what I know, Parikshit sir and Jaideep sir and their team, they give a choice of three drugs. That either this or this or this. Tumko jo zyada pasand hai wo tum lo. Something like that.
Okay. And when should a center who is running a batch IVF should shift to a continuous program, or like, do it continuously? After how many number of cycles?
See, now, madam, that is going to be dependent on the ambition of a person. Majority of the people who start batch IVF, they start because they have a fantastic routine OBGYN practice. And every month they are having, let's say, 5 patients. I'm giving an example, whom they are currently referring to a IVF friend of theirs. Okay. And remember one thing, the greatest IVF consultant in the world will not exceed a result of 50%. Okay. On the best possible month, best possible day, irrespective of the marketing. All right. And the worst person will usually not go down below 10 to 15%. Correct. So this many people are like that I'm very happy with my 5 to 10 IVF cycles, which I do, but I want to give the best possible results to my patients. Understanding, because now I have a huge practice. So my reputation is driven on how good my IVF program is. Okay. So those are the people who never want to expand and they always want to do batch IVF only. Then there are some people who will say that, boss, I'm doing 10 IVF cycles. Next time I'm going to be doing 20. They are going to be very aggressive. They want to do that little extra efforts, push in patients, counsel more patients. It's really human, I think.
So with batch IVF, you said it is cost effective. How much the media cost will come down if you do it in batches?
You just have to open one bottle. Remember, one bottle media, if you buy, some media has concentration of 10 ml. Another media which is available has concentration of 30 ml. Let's assume you are buying single step media. Okay. How much is the media which we need for culturing 10 embryos of a particular person till day 5? Less than 500 microliter. No. How much is the amount of media which we need for doing embryo transfer? Less than 100 microliter. Correct. So what typically happens is that in this entire thing, that bottle which you open is a pack bottle which you have opened and you have used almost everything. Correct. So the efficacy of that media is very high. How much is the standard cost of a single step media 30 ml? Around 6,000 to 8,000 rupees. Correct. If you are not a very regular customer, let's assume you are doing 2 cases every week. Correct. This media will ultimately expire after 1 to 2 weeks. So your effective use of the media goes down. The same thing will happen to drugs. The same thing will happen to your beds. Same thing will happen to your consumables. Everything will be the same. Understanding. And more importantly, as an individual doctor, you will save time. You know that in a particular month, if you are, let's say, doing 25 IVF cases, you don't have to devote more than 2 days in a month to do IVF. The rest 28 days, you are free to do what you want to do. Something like that.
Okay. And so QA, QC and all, I mean, it has to be done beforehand, like how long before, if they're doing alternate?
Not mandatory, but on T-7th day or T-10th day, in that window which I marked, T-7 to 10 is when you should do your QA, QC.
So do you recommend all the batch IVF units to have their own in-house embryologist, like a junior embryologist who take care?
Some people want to have it because they want to keep that embryologist for inspection, supervision, and record keeping and paperwork. Okay. There are many people who these days, even embryologists travel, like whenever my team goes somewhere, there are 2 people who go in embryology only. So one does the helping work, another does the main work. Okay. So it's up to everyone.
So the mock thing you said has to be done. The running of the embryology unit.
A dry run of the lab. What I mean by that is your incubator is switching on correctly or not. Okay, your ICSI plates are getting heated or not. Because remember, in periphery, if you want to order service, it will take 3 days. Okay, for a service engineer to come and repair that particular thing. Okay, see, honestly, I learned maximum repair and maintenance when I was doing traveling IVF work, because I had no one to repair the instruments for me. Correct. So we remember once when we were in Nagpur, myself and Mohit had repaired an entire suction pipette on our own. No manual available, nothing available. Both of us juniors. I was 28, he was 31. I distinctly remember this. Okay. And we were like, ab kya karne ka? And we repaired it. We used some logic of physics. 2 patients became pregnant out of 7. Okay. Not bad. 35% result still. Okay. But remember one thing, one important thing. When you do batch IVF, you give importance to IVF also. Don't only rely on ICSI. Okay, because it is going to happen that, let's assume in a particular batch, when you have, let's say, 15 patients, you have 100 oocytes. No matter how good an embryologist you are, there will be some fatigue after doing 60 to 80 oocytes. So you must really calculate which patient is good for IVF, do IVF in them. Okay, all you need to do is denudation. Just use a 300 micropipette and denude next day morning. No, 50% would have got fertilized any which ways. Correct. But that is important. Okay. And that will teach you which patient to do IVF and which patient to do ICSI. Otherwise, in your private practice, you will be shit scared and you will be doing ICSI only for everyone. Okay. But batch IVF will teach you how to use IVF very much correctly. And that is something which you will learn in batch IVF.
So do you do sperm survival test to check if it is?
No.
So for all cases, you stick to only antagonist protocol, or is there a role?
All cases, antagonist protocol, equally good results, very convenient, no jhanjat of giving agonist in the night, agonist bhul gaya to abhi kya, nothing like that. Nothing like that.
So what if there is micro PSA or PSA to be done on the same day? Like
it has to be scheduled 2 hours after the pickups. Because by that time, the oocytes would have been denuded. And after you denude the oocytes, you have approximately 30 minutes before you do ICSI. Correct. Oh. So in the 2 hour window, no, you should finish off PESA, TESA, micro-TESA.
So what about mixing of gametes, like same names, same husband name? I mean, have you encountered such things when you have traveled?
So this is a very practical question. And I had a very beautiful system of preventing mixing. Okay. Now let's assume in a particular batch, we have 3 Shilpas. Okay. All of them, let's assume, one person's husband's name is Rajesh, another is Mahesh, and third is Pinkesh, whatever. Okay. So your Heracell box incubator has 3 compartments. Okay. Your different Shilpa should be in a different compartment. Understanding? That will prevent the mixing better than any RI witness system. Because remember, you don't have that time in a batch IVF to do that witnessing, code, recode, put a new plate, code that plate, put an catheter, code that catheter. You don't really have that thing. Okay, so this is one very nice way of doing it. Second very nice way of doing it is that the first Shilpa should be the first patient. The second Shilpa should be the 4th patient. And the third Shilpa should be the last patient. Okay, automatically what will happen is, in that distance which is maintained between the 2 or 3 Shilpas, what is going to happen is that your sperm preparation will be done separately at different times. So your error rates will go down. Okay. And like nowadays, very good softwares are available. So patients have their photos marked on it, and you can easily judge which patient is which based on the photographs which you are seeing, because all the laboratories also have the same software.
Yeah, I think we have covered most of it. But for how long did you do this? The batch IVF, like how long you were involved?
1 year. 1 year.
Okay. So what is the frequency with which many centers do it? Is it like once in 2 months, once in alternate months, or how does
once
it go?
Once in 6 weeks, madam. Once in 6 weeks is what people normally like to do it.
Okay, but the results are reasonably comparable to the continuous.
Absolutely good results, madam. Even in all the batches which we did, we were touching approximately 30-35% results in 2015, which is a good result at that point in time. Okay. And in fact, after I stopped, Mohit continued to do for another 1 to 2 years. He was also going to Coimbatore, Erode, many places actually in South India. And he never encountered a loss of results in that thing.
So do you have this backup like spares? See if the suction pump goes off or if the incubator conks off, like what do you do in such cases? But the bulb goes off.
Freeze the oocytes. Okay. If the incubator goes off and you have only a single incubator, freeze the oocytes. If the incubator goes off on 3rd day and you have planned for blastocyst transfer as a fresh transfer everybody on day 3. Okay. If your airflow, airflow also has a stereo zoom microscope. It will happen many times in periphery. The light when you press, there is UPS is not connected to the airflow because airflow is not an important equipment. Understanding that nothing. Mobile phone has torchlight, just put that torchlight in front of the mirror. It will reflect the torchlight up and you will be able to finish off your work. So, but your phone should charge. I mean, all these things are important because all this you will learn in doing all these things.
So how many
One more
days-
thing, sorry, I want to add one more thing. Commonest mistake which happens in batch transfer is your oocyte plate will spill. See, many plates are kept simultaneously, in the airflow. So you've got first oocyte. Let's say what we used to differentiate was Mohit would do pickups and I would be in the laboratory. Okay, so he will finish off pickups and there will be 10 tubes to examine. By the time next patient is already shifted inside, what will happen is that you are very fast trying to screen the oocytes inside that. Sometimes, you are trying to hold the plate very nicely. You will walk at a snail's pace and put it in the incubator and all these things. But sometimes that plate will spill on that airflow. Fir kya karega? Then what you will do in that situation? All these things happen very commonly. Nothing to be done. Take the largest pipette which you have available. You will rescue out of 10 8 oocytes. Okay. Very common. You don't need to add any antimicrobial, nothing in the culture. God will take care of all these rare events because all these things have happened with all of us. Okay. Patients will still become pregnant. Oocytes will still fertilize in all those things. I'm telling you, our suction pipette broke. Imagine. Okay. And we were still able to perform ICSI. So it's okay.
So ideally, how many days you travel? Like 2 days, 3 days, or day 0 is the day that OPU has to be done. From there
on day 0, what we used to fix, we had a belt. Okay, so from let's assume Nanded, Latur, Hyderabad, Warangal, Nagpur, all this is in the same circuit. Okay, so first day we will finish pickups in, let's say, Nanded. Then you have 3-day break or a 5-day break for day 5 transfer. You don't have to go inside the incubator and check every day. All that cannot be done in batch IVF. Understanding? By the time it is the 5th day, one person will come back to freeze everything. Okay, the second person will go back to Bombay and the third person will join in the team. So all that micro adjustments were very common, are very common.
Okay, yeah. Okay, I think we have covered almost everything, I think. So what about PCP and DT? I mean, do you apply for it?
We had applied at all units, madam.
Yeah. Okay, somebody asked in the thing. So I thank you so much. I mean, it was wonderful. I know it has not been discussed many a times and not much literature is available and not many books are available on this topic, and it is mostly about your practical experience and troubleshooting that you had during your personal, I think, case handling. So thank you so much for sharing it all with us. I hope it's useful, and I encourage all the people to see our previous sessions also, which are quite informative. So thank you. Good night.